Hi, everyone. Welcome back. I'm Dr. Samantha, the maternity mentor, and I'm here for another one of our live Q&A sessions that we have every Monday at 9 p.m. Eastern Standard Time. This is your chance to ask me any questions live, as well as my chance to answer any questions that you guys may have put into the chat. I am still a little bit under the weather, as is my producer. So if I seem a little bit muted today, it's because of that. And of course, you might hear him cough. So I'm going to go ahead and get started on some of the questions that you guys have left me, but please feel free to put any questions into the chat. Remember to like and subscribe to the channel, because subscribing to the channel really helps me out as a content creator. So I'm going to go ahead and get started. I don't have a lot of questions, so feel free to answer or ask any questions. I had a question on antibiotics, and I think it's a good place to start because irony, I'm been sick for the last couple weeks, and it says, I'm 19 weeks pregnant. Is it okay to take cefuroxime for my urinary tract infection, UTI? So the answer is yes. Cefuroxime is one of many antibiotics that you can take during pregnancy safely to treat a bacterial infection. One of the most important things you guys need to be aware of is that you should only be using antibiotics for a bacterial infection. The reason for this is antibiotics are not going to treat fungal infections, yeast infections. They're not going to treat viral infections. And part of the reason why we have so much antibiotic, antibiotic resistant infections is because of our overuse of antibiotics. And so now the bacteria are stronger and it's harder for us to kill them off of the antibiotics. I was actually talking with a client recently about antibiotic use. One of the things I was explaining to him is this. I know I've said it on the channel before. We don't really use antibacterial like soaps, and we don't use the sprays. I mean, we have some left over from COVID because everybody had them during COVID. None of us knew exactly what was there, but on the regular, we don't use it. Oftentimes I clean my counters with just vinegar. It's just not our thing. And my dish soap, it's not antibacterial. I don't use bleach in my bathrooms. That's not something I do, because this is creating antibacterial resistance. Okay. First of all, when you're cleaning, most of what actually gets stuff clean is friction, and the soaps, where they're lipids, it carries away dirt and bacteria. It's not actually that germicidal type of stuff. And what we need to understand is, when you are taking too many antibiotics, you are contributing to the problem of antibacterial resistance. But it's not just you, it's everyone in your community. So imagine you live in small town USA, right? So just because you don't use too many antibiotics does not mean small town USA won't develop an antibacterial resistant bacteria. Because if everybody around you is using too many antibiotics, then that bacteria is going to adapt. That's why it's so important for all of us to not overuse these drugs. And it's very challenging as providers, because there's a lot of pressure put on providers to give antibiotics when somebody is sick. I hardly ever ask for antibiotics anymore. It's something that I really try to avoid, because there are certain situations where I have to use them in my family. And so there are people out there that have to use antibiotics regularly. So to protect the rest of us, is important to be very careful about what we use. And one of the other ways that we can actually reduce antibacterial resistance, and actually there's viral resistant viruses, or antiviral resistant viruses. I mean, these superbugs are out there. And so one of the things you can do is not only reduce your antibiotic use, but you can also reduce using all this antibacterial stuff. It's not necessary. And it really can help to protect your health and the future health of your family. What is actually the most effective stuff? washing your hands often, cleaning off surfaces, being mindful of how you wash things. A great example, when you're washing, say, a cutting board that you just put raw chicken on, you want to make sure you wash it with a lot of soap and hot water. That's what you do. One of the things we do in my house is we don't use sponges. Those grow a lot of bacteria. And I don't want to use something disposable. So we actually have a whole bunch of like cloths, like cotton cloths, right? Washcloths. And we use those to wash our dishes. And then I can just throw them in the washing machine. And when I wash my cloths, I use regular soap, but I wash it with hot water. And then when I dry my stuff, I dry it on a very high heat to help to sanitize it. So that's how I kill off stuff in my, like, for example, my sponges without using an antibacterial type of soap. So going back to this question, yes, it's important for pregnant women to take these antibiotics. And I want to be clear about that. You need to take it exactly as directed. It's very important that you do that. Take every single pill, because if you don't, you can create a bacterium in your body that will be more treatment resistant. And pregnant women are immunocompromised. And if your infection goes untreated, you're at risk for miscarriage, preterm birth, and stillbirth. Okay. So pregnant women are one of those people that have to take these antibiotics, which is why it's important for the rest of us to be more careful with it. Okay. So I had a question on my blood pressure video. Blood pressure is a very important issue that pregnant women can face. It's becoming more common and it can be extremely deadly. So we have to be very careful with it. So it said, I developed high blood pressure at 28 weeks pregnant. And last week at 32 weeks, I gave birth via emergency C-section due to very high blood pressure and protein in my urine. My baby is premature and currently in the NICU, but she is not accepting or digesting formula milk. The pediatrician suggested I express breast milk and feed her. However, my cardiologist advised against breastfeeding while taking amlodipine and labetalol. On the other hand, my gynecologist says it's safe to breastfeed while using these medications. Could you please suggest a solution to my problem? So this is a very common issue that we find where we have a mom who has to take medications basically to save her life. Blood pressure medications save your life. And then there's all this confusing information about the medications and their safety for babies. So let me start by saying that you want to defer your opinions about the safety of medications to people that are more specifically tuned in to taking care of moms and babies. So number one, the neonatal intensive care staff, okay? Those neonatologists, the nurse practitioners, the nurses, they're used to taking care of premature babies. They have seen other people with high blood pressure. They've heard these drugs a million times over. If your medications were not safe, they would not allow you to provide breast milk. They can't control what you do at home, but in the NICU, they control every single bit of it in order to get your baby home safely. So in the neonatal intensive care unit, the NICU, if they're saying they want your breast milk, that they want you to provide it, and they know your medications, listen, then that right there is your answer. I promise you, they research every single thing. Now, let's pretend they don't. Let's pretend they've never looked at anything. Now we go to the pediatrician. So the pediatrician also has a vested interest in taking care of your baby and making sure your baby is healthy. Pediatricians are also very familiar with the use of breast milk. It is the preferred option for feeding babies if available. If the pediatrician questioned any of that, they would absolutely be saying, no way. Next, we defer to the OB-GYN, which in this case is also telling you it is safe to breastfeed and provide breast milk with these medications on board. So this is another thing that's your hierarchy. That cardiologist probably sees a pregnant person once every million years. I mean, it's just not going to be something common unless it's a cardiologist specializing in reproductive health. Now, maybe you are not 100% comfortable with what everybody's saying, right? Sometimes people look at the cardiologist, right, as like more important than say the OB-GYN. I would challenge all of you guys. These guys are all in an even playing field. There is no hierarchy in who is maybe more knowledgeable or more important or anything like that. Your cardiologist, generally speaking, he's going to know, or she is going to know cardiology. So sure, in that realm, as far as treating your cardiology problems, absolutely better than the OB-GYN, but not necessarily in breastfeeding or breast milk. Okay. Now, one of the things that I am doing right now is I am looking up those medications. So let's say you're kind of like still on the fence. So what do? Maybe only one of these people has been involved in your care. You're just not really sure. What is another option? So one of the other options is a pharmacist. Pharmacists have specialized training in medication. That's like all they do. They have access to a whole bunch of different databases. These databases aggregate safety data and any studies and anything like that that they can get their hands on. So they're able to give you some good counseling on it. Additionally, there are resources like what I just looked up, which was Thomas Hale, the infant risk line, right? So Thomas Hale is a pharmacist out of, I think it's University of Texas, and he runs the infant risk line, which anybody can access. It's online. It's something, there's a hotline, and you can actually call them up, even as just a regular person, tell them what you're taking, and they will give you some information. But he also has developed a risk scale related to pregnancy and to breastfeeding and medications, right? So I can tell you, I've seen labetalol used over and over and over and over and over again. Labetalol is one of the safest medications for preeclampsia during pregnancy. It is very commonly used. It is safe during pregnancy and is safe for breastfeeding. So this is very commonly used. Amlodipine is not used as commonly. This may be the one that the cardiologist was honing in on. I'm not sure, but we don't see amlodipine used as often. So what can you do? You can reference some of these guides. And so, for example, what this is saying is multiple case reports demonstrate low levels of amlodipine in breast milk. That means there's not that much in there. And since it does have a long half-life, that means it lasts for a long time. We don't know exactly how much the baby's going to get. If I was a lactation consultant working on your case, what I would be approaching the OB-GYN and the cardiologist and saying, hey, is it possible for us to replace the amlodipine with something else? Maybe possibly nifedipine or something like that. That's one of the discussions that can be had. They may also be able to raise your labetalol enough so that you don't need the amlodipine. You can ask the neonatal intensive care unit about donor breast milk. I have a video on donor breast milk. If donor breast milk is coming from a legitimate source, donor breast milk is one of the best things out there for babies, especially medically fragile babies, and it's life-saving. It's like a medicine. But ultimately, the neonatal intensive care unit, they're the ones that know what the safest thing for your baby is. They are looking at your breast milk as medicine. Now, your breast milk may contain some of these other things, but for them, if your baby is not tolerating formula, they may feel that it is much more beneficial to get your breast milk than nothing at all. So that's where I go with that. For any of you guys who are joining me, please feel free to put your questions into the chat. I had a question on my drying up breast milk video, and it said, I lost my baby 1 year ago, but I'm still struggling with breast milk production. And this is very sad, and I'm sorry to hear this for this viewer, and I hope that you are, managing as best as you can, because it's hard to lose a baby. Breast milk production can actually happen for a lot of different reasons outside of pregnancy. And stress is one of the most common ones. It can also happen due to increased prolactin levels. Prolactin is the milk-making hormone, and we can actually see prolactin levels increase due to other medications and things. One of the medications I commonly prescribe for psychiatric illness is antipsychotics. It's a category called antipsychotics, and it can actually cause men and women to develop breast milk, even after like they're in their, 60s, 70s, 80s. And of course, you just heard me say men can make breast milk if their prolactin is stimulated enough. So it's one of those things that we can get that for other reasons. You can also get increased prolactin levels from something called a prolactinoma. A prolactinoma is a tumor. It's a tumor of the pituitary gland. The pituitary gland is a gland inside your brain. It's right behind your, right behind here. And it sounds very scary. It's a benign tumor, so it's not something that's going to like develop into like cancer or anything like that, but it does need to be removed if you have one. And so it requires what sounds really scary, brain surgery. But what they do is they go up through your nose and they just make a little hole and they take it out. It's very common surgery. It's very easy. It's very safe. But that is something that can also cause that. So for somebody who's been making breast milk for an extended period of time or suddenly starts making breast milk for no apparent reason, there's no medications on board or whatever, it is something that should be checked out with an endocrinologist. Those are the doctors who specialize in hormones, and they can do stuff like order an MRI to make sure there's no prolactinoma and the like. So I had a question on hyperemesis gravidarum, otherwise known as morning sickness. It said, I couldn't eat well during my first trimester. Is it too late to start eating well now at 5 months? And the answer is no. You can eat well at any time. There are a lot of people who cannot eat well during their pregnancy for a variety of reasons. They struggle with, what they're able to tolerate. And so you do the best that you can. If it's not until you're 5 months along before you can start eating well, then you eat well then. Anything is better than nothing, guys. Even one day of good eating is better than nothing. Pregnancy is very hard. There's a lot of changes. So it's one of those things that you just want to keep trying. That's the best thing you can do. Okay. Any of you guys who are here, please feel free to put your questions into the chat. Sorry, guys, I'm still a little sick from like last week. So if I sound funny, that's why. Okay, so I had a question. I had two questions actually on my preterm labor. So one of them said I'm 28 weeks pregnant. My cervix is 0.9 centimeters. While I've passed the cerclage cutoff time, I'm using suppository progesterone. The doctors say there's nothing else they can do at this point. They want me to limit my movements, but they haven't prescribed bed rest. I'm confused and very worried. The next one said, I'm 16 weeks and 2 days pregnant. My cervical length is 30.1 millimeters, which is 3.01 centimeters. At 13 weeks and 3 days, it was 39.3, 3.93 centimeters. My doctor says above 2.5 is normal, but I'm not sure if this is okay. They want to check me again in 3 weeks, but I'm worried this might be too late. Could the nurse have made a measurement mistake? The doctor didn't prescribe progesterone tablets, and I'm very concerned about the decrease in length over 3 weeks. Should I be on complete bed rest? So, two questions with two pieces of information that are they're very important. So, let's start with cervical length. So, cervix kind of looks like your fingers, okay? It should be long, thick, and closed, okay? And a cervix is not completely closed. It has to be able to dilate, right? So this actually looks like a cervix because this is what it kind of looks like. And this is where your mucus plug is to block up that one little space. And this end of your cervix actually kind of feels like the tips of your fingers, okay? And so the cervix is supposed to be like this. The length of your cervix is kind of a fixed thing as far as what you have normally. Some people have short cervixes normally. And then we just go from there. Cervixes can shorten over time. What that basically means is that they're starting to dilate, right? But sometimes you stay closed, but the cervix is shortening because it's effacing, so it's pulling up. So what the second question said, where it said they want it to be above 2.5 is true. they want it to be above 2.5 centimeters. So 3.93, those are fine. These measurements are being taken off of ultrasound, and ultrasound is finicky, guys. I know we're in 2025 and it gets better every year, but it is still finicky. It's not a perfect measurement. We still stick with ultrasound because it's no radiation compared to some of the other things, but this is what we have. So it's not a perfect science. Now, but the change in the cervical length can be an issue. But have I seen them check it again and then it goes back to longer? Yes. Does that mean it lengthened? No. It just means that the original measurement was probably off a little bit. Okay. Now, bed rest. Progesterone. So not every doctor is using progesterone anymore. There's been some newer research that's now showing that progesterone may not help with preterm labor or anything like that. It's not harmful, but it's not necessarily helpful. So there's a lot of doctors who are still using it because that's what they're used to. That's like their protocol. And that's fine. But there's a lot of doctors that are not using it anymore. And that's also fine because the data just isn't there. And inserting things into the vagina is risky because you could induce infection. And then oral progesterone is not necessarily going to help. So that's why you see the two discrepancies in these two questions. So now bed rest. I have a bed rest video. So bed rest is controversial. During pregnancy, you are at risk for two things. The first thing is you're immunocompromised. This means you're at risk for infection. This is why we're very big on trying to vaccinate pregnant women, because pregnant women are at high risk for serious illness, hospitalization, and even death from certain infections like the flu or COVID. And I've seen it, guys. So there's no denying it. I've lived it. I've taken care of these people. So that's why we're so big on making sure we're careful about making sure pregnant women get the right care and try to avoid illness. But inevitably, if you've been pregnant or you know somebody who's pregnant, what do they say? They're sick. They're always sick. Pregnant women always get sick. And part of the reason why we also know this is because what is one of the most frustrating things about being pregnant? You can't take any of the medications over the counter. In case you guys didn't know this, you can't take any cough or cold medicines over the counter when you're pregnant. They're not allowed. They're not safe for the pregnancy. So you're stuck kind of getting through it, right? So it's tricky because if you're at high risk for getting sick, any illness can develop into something more serious like pneumonia. Okay, so pneumonia is a bacterial infection of the lung. It is very serious because it can cause issues with breathing. And if you have trouble breathing, then you have trouble oxygenating. That means bringing oxygen into your blood. Well, the only way your baby gets oxygen is if your blood has oxygen in it. So if you can't breathe right, then the baby's not breathing right. So it's very important that we keep you oxygenated. And so therefore, we don't want you to get sick. When you're on bed rest, part of the way we don't get pneumonia when we have a regular cold, like I have a cold right now, right? And part of the reason why I am very likely to not develop pneumonia is because I walk around. So when I'm standing, I am able to expand my lungs and take deeper breaths, right? When I walk around, I move my body in different ways. I move my lymphatic system. That's the part of your system that deals with infection and it moves stuff around. So movement allows me to be healthier in general, even when I'm sick, and that helps to prevent me from getting worse and developing something like pneumonia. Also, when I'm walking around, I am able to take deeper breaths and stuff like that. That also expansion of the lungs prevents pneumonia. When you are on bed rest, that means you're not moving around as much. Additionally, your posture on bed rest is usually not like up and expanding your diaphragm. A lot of people are laying back. That's putting pressure and compressing the lungs and stuff like that. So women who are on bed rest are at much higher risk of developing pneumonia because they're not expanding their lungs, they're not moving around, and they're already prone to infection. So this is one of the reasons why we don't like to just encourage bed rest. Now, the second thing is because of blood clots. So women who are pregnant are at higher risk for blood clots. This is because during pregnancy, you have more clotting factors in your blood. So clotting factors are parts of your blood that when you get cut, it prevents you from bleeding and bleeding and bleeding. You know, when we get a little cut, it'll just stop bleeding almost right away. That's because these clotting factors, these things that come and stop the bleeding, are in our blood. Well, during pregnancy, you have a lot more of them. And so the thing is, blood clots are usually prevented by movement because we usually get them in the legs. That's the most common place to get them. Now, what you can do is you can get a DVT. I think I have a video on that. I'm not 100% sure, but you can get a DVT, a deep vein thrombosis, or a blood clot in your leg, and it can basically move, and then it can go in other places in your body, which can be a medical emergency. So my producer's saying I don't have one on DVT, so I guess I need to do one on DVT. One of the reasons why they tell you if you're pregnant and you're on a road trip, you need to get out of the car every hour and walk around, or if you're on a plane, you need to walk around, is because it helps to prevent blood clots. That's why you're doing it, to move your blood, move your body, and make sure you don't develop one. Because when your leg stays just flat and stationary, the blood just sits there. I mean, it's moving, but it's not moving well. And so you can get a blood clot easier that way. In the hospital, when we have people on complete bed rest, we have these machines that will pump the legs to try to simulate walking around, to try to simulate that artificial movement. So if we put you on bed rest, we are also putting you at high risk for a clot. And if that clot develops, there's a lot of complications that can happen. So pneumonia and blood clots, two very big reasons to not be on bed rest. And that doesn't count some of the other stuff, like the fact that you can get muscle atrophy. Women's muscles will oftentimes degrade. That can put them at risk for C-section because they're not able to push. You can get mental health issues like depression and anxiety, and the list goes on. So we want to use bed rest when it benefits mom and baby, and we need to be careful because sometimes the risks are not worth it. Now, there are a lot of different modified versions now of rest, and this is what I need to be careful. When we heard about complete bed rest, it was such a powerful intervention, and it made everybody understand, not only the woman, but her family and her community, that serious things were going on, that it made a lot of sense to us that this was a big deal. This person needs a lot of help. There's a big deal. We're trying to save a baby. What people don't realize is that partial bed rest or partial restriction of movement is just as important, and now we know is much healthier. Bed rest will sometimes be called bed rest, but there's actually a lot of different versions of it. For example, some women are in complete bed rest. This means they don't leave the space that they're sitting even to go to the bathroom. They have to go to the bathroom using a bedpan. Some people have to pee in a bedpan, but they can go to the bathroom to have a bowel movement, et cetera, et cetera, et cetera. So for my two viewers here that are concerned about this restriction and should they be on complete bed rest, I would say if your doctors are not asking you to be on complete bed rest, you shouldn't. However, you do want to talk to them. Maybe they do want you to be hanging out in a chair or couch 7 hours a day or 10 hours a day. Maybe they don't want you walking stairs. Maybe you shouldn't be taking showers. Maybe you need to be taking a stool softener to avoid constipation. So these are some questions that you can go ahead and ask them. And that's one of the things I would tell you to do. So I hope that answers those questions. For those of you who are joining me, hi, I'm Dr. Samantha, the maternity mentor. Please feel free to put your questions into the chat. If I'm a little off, it is because I have been sick. That's why I missed last week, and I'm still a little sick, and apparently talking is like stirring everything up. So I only have a couple more questions, so please feel free to put your questions into the chat. So I have a question on second trimester bleeding. It says, I'm 28 weeks pregnant and seeing small drops of blood. Is this normal or abnormal? Okay, so first of all, a lot of people know I have a video on bleeding in the first trimester. Please feel free to check it out if you're first trimester or know somebody. Bleeding in the first trimester is extremely common. There are a lot of reasons why somebody might bleed, and it is normal. So you should always contact your healthcare provider, but there's a lot of reasons why you can sometimes breathe a sigh of relief. Once we get into second trimester, we get a lot more concerned. So second trimester bleeding, a lot of the reasons why you see it in the first trimester that are normal, they don't occur anymore. It's possible, but it's not probable usually. And so usually in the second trimester, when we're seeing drops of blood, it's more of a warning sign. So drops of blood can happen because you're developing an infection, whether it's a urinary tract infection or some kind of vaginal infection like a yeast infection. Those are reasons why you could see drops of blood. We don't want to see that, right? Second to that, we also may see drops of blood because there's a placenta issue. Actually, let me just look. So this person's 28 weeks pregnant. So I would find it highly doubtful that there's a placenta previa. And I have a video on placenta previa. Basically, the placenta is the organ that feeds the baby. It attaches to the uterine wall. There's a whole bunch of blood vessels, and blood vessels they attach that creates the feeding system. A placenta previa is when it goes over the cervix. So then if the cervix dilates at all, there are blood vessels that are exposed and you can get some bleeding. At 28 weeks pregnant, I find this to be highly unlikely because you probably have had an ultrasound at this point, which would show that. There are potentially subchorionic hemorrhages, but you could also have an abruption. Abruption is a medical emergency. Abruption is where the placenta actually detaches from the wall. So if you're starting to have a partial abruption, even a tiny little piece of the placenta detaching, you could see bleeding. So it's very important that if you see any kind of bleeding, that you contact your healthcare provider immediately or go to a hospital to get checked out, because you need an ultrasound. That's like number one. You need an ultrasound so we can see what's going on. It is possible that it was caused by sex or like maybe wiping or something, because the vagina is still very dry in the second trimester. Throughout pregnancy, the hormones that drive a healthy pregnancy dry out the vagina. And so that can cause things to be, it can cause you to get little micro tears that can cause some bleeding, especially in the form of drops of blood. So it's one of those things that you definitely, it could be it. When you're talking about blood, it's especially smaller amounts of blood. I encourage people, in this day and age, we all have a cell phone. Take a picture of what you see so that you can show your provider what it looks like. There is a big difference between drops of blood on your underwear and drops of blood on your toilet paper. So generally speaking, drops of blood on your toilet paper is less bleeding than drops of blood on your underwear. And a lot of people don't realize that, but that's usually the case. If you see any drops of blood, sorry guys. If you see any drops of blood, you want to go ahead and put on a panty liner or a pad so that you can see any future drops of blood. But it's very important that if you are putting a pad on, every time you go to the bathroom, you replace that pad, even if there's no blood on it, because you don't want something, there's still normal vaginal bacteria that's going to come out of the vagina and sit on that pad. You don't want to keep putting a dirty pad on. So if you do, no matter what, you want to change that. And then we have a video on the colors of blood and stuff like that. Check it out. It's important to understand the colors and the quantity so you can explain it to your healthcare provider. But if it's red blood, that is considered to be an active bleed, and it's something that you need to take seriously. But ultimately, guys, your healthcare provider, midwife or OB-GYN, they're paid to be there 24/7. Okay. They either are on call or they have somebody who is working for them on call. You need to call your healthcare provider. Who cares if it's 2 drops of blood at 2 in the morning? It is way better to get that phone call and ask what you're supposed to do than to ignore it and something could be going on. Okay. So definitely contact your healthcare provider. Okay. I have 2 last questions. So if you guys have any questions, please feel free to put them into the chat. So these 2 questions came in on my yeast infection video. So just a reminder, like the yeast infection, this is a fungal infection, and fungal infections are not treated with antibiotics. They're treated with like antifungal medications. So one of them said, my doctor wants me to use Turconisol 0.4% vaginal cream. The other one said, what happens if I need to urinate in the middle of the night after inserting my Conazole? I'm 37 weeks and frequently urinating at night. That second question was brilliant, by the way, because I had never really thought, I know the answer, but I'd never really thought about saying the answer out loud. And I'm sure a lot of people actually wonder that, right? So let's start with yeast infections in general. Again, women are immunocompromised during pregnancy. It's going to put you at a higher risk for getting a yeast infection. Women are very commonly getting urinary tract infections during pregnancy, which have to be treated with antibiotics. Once you get an antibiotic, that puts you at risk. Say hello to Faye, everybody. She is here for one of our lives. It's my cat. So, this is, so when you take an antibiotic, it puts you at risk for potentially developing this yeast infection, right? So if you get the yeast infection, now we got to treat it. Now, one of the things that's very confusing is if you get a urinary tract infection or something like that and you need an antibiotic, one of the things that happens is that you have to get a prescription, but you can't get a prescription, or sorry, most people don't get a prescription for their yeast medication. It's just in the pharmacy, right? It's something that you can go ahead and you can find just readily available. Well, when you're pregnant, you can't just grab it off of the shelf. That's not something you can do because it is not safe for you to just determine what kind of medication to take. So, for example, we are given 2 different medications here, and there are 2 different safety profiles for these medications, which I'm going to tell you about in a minute. There's different forms of yeast medication. So there is oral, which are pills. There is suppositories, which is like a little gel pad. No, not gel pad, like a gel capsule that you insert into the vagina. And then there's creams. Depending on your particular provider, they may feel it's more important to use one versus the other. If you have certain conditions, like let's say you are high risk for a premature rupture of membranes, that's where your water breaks, then they may not want you to insert anything at all. And they may want to do a pill. So you need to talk to them first. Now, if you've used a suppository, what happens with them is it's like a gel capsule kind of, right? So you insert it and the outside eventually melts down, releasing the medication. So there's going to be drippage. And of course, anybody who's used the cream, there's always a little bit of drippage, right? So a lot of people get really worried about what do I do when I stand up because it's going to come down, right? So there's nothing you can do. You have to pee. The bottom line is some of it's going to come out. So you do the best you can. So what is the most important thing? Do not insert your yeast infection medication until you are 100% ready to lay down for as long as possible. And right before you do it, go to the bathroom. Okay. So you need to have like done everything, crossed every T, dotted every I, you've read your book, you've done everything. You go pee, you come back, you put it in and you lay down. And then as much of it gets absorbed as it gets absorbed. That's all you can do. Sorry, guys. So safety. Let's start with Turconisol. So Turconisol, a vaginal cream, is highly absorbed into the vagina. It's something that will be taken up into the tissues. If you're pregnant, you've got a baby sitting right there next to those vaginal tissues. So the baby is by default probably going to get some of that in through the placenta, right? So Turconisol is not recommended in the first trimester of pregnancy. There needs to be a significant risk versus benefit analysis done. If you have a treatment-resistant yeast infection, then maybe they're going to want to do that because you're at risk for miscarriage. But Turconisol at significantly higher doses than what's given to a human being, but in animal studies has been shown to cause birth defects. So let me just say that again. We don't do studies on human beings. In animal studies, at doses significantly higher, like 10, 20, 30 times higher than a human dose, animals do sometimes get birth defects. So it is one of those things that we don't recommend in first trimester if possible. Now, Turconisol, second, third trimester, it's a risk versus benefit, meaning there's no evidence to say that there's any harm, but we just don't have a lot of evidence at all. Miconazole is a similar like a similar profile, right? And what it is that it is absorbed through the vagina. We don't know. Now, in that case, there's no animal studies really saying that there are birth effects and it gets absorbed at a lower rate, but it is still like potentially an issue. So if you don't need to take it in the first trimester, then we want to try to avoid it. But usually miconazole is preferred over Turconisol. So I hope that answers that question. Hi, Wafa. Hello, just found this by chance. For folate, can we take both 5-MTFH and folic acid, or is it better to take only one type? Oh my gosh, you must have been in my office today as I was talking about this. So this is a huge issue that I am currently actively trying to get guidance on. I'm going to be talking to a couple of functional medicine physicians. I've been searching the internet high and low. I can't get evidence from March of Dimes. This is an issue, guys. Okay. So L-methylfolate is a broken down version of folic acid. It is basically, it's better metabolized by people, especially who have the MTHFR genetic mutation, which means they can't process normal folic acid. Folic acid is essentially important for your body. It is one of the building blocks of cells. And as we know, for a healthy pregnancy, you need to be able to take folic acid because without proper folic acid, you are at risk for neural tube defects, right? The baby is at risk for neural tube defects. And neural tube defects, for anybody who knows, includes brain abnormalities and spinal abnormalities. And this can be anything from, like, sometimes the skin doesn't form over the spine isn't complete, the brain isn't complete, like there's serious abnormalities. So we know folic acid is important. If you have MTHFR, you're going to have trouble processing folic acid, so then you might need this L-methylfolate. So here's the challenge, because I have a lot of patients who are coming to me now who've been given a prenatal that has L-methylfolate only. A lot of these newer prenatal vitamins have only this and not regular folic acid. I have been doing a lot of research. You can actually overdo it with folic acid, and L-methylfolate is still basically folic acid. So you can overdo it, overdose, have serious significant side effects if you take too much, right? And what I'm finding in some of these prenatal vitamins is the amount of folic acid is pretty high because generally speaking, the B vitamins are water soluble. You just pee out the extra. So having a little bit extra on board isn't usually a big deal. Except when you go to the standards set forth by like American College of Obstetrics and Gynecology, ACOG, March of Dimes, and other research studies, the research has only ever been done with regular folic acid. Okay. So regular folic acid is the only thing we know for sure prevents the defects. A lot of people will say, but isn't L-methylfolate the same thing? Sort of, but not really. And because there is a slight difference, there is no evidence to support that L-methylfolate is enough. So there's some references in literature that talk about you should tell somebody to take both, but I can't tell you on that what the dosing is. That's what I'm trying to discover for some of my patients. I am not 100% clear on how much of each. You can overdo it. So you need to go to your healthcare provider and talk to them. What gets even more confusing, guys, and this is one of the things that I've also been finding, at least here in the US, I am having women send me the names or pictures of the bottles of their prenatal vitamin. And when I look at the back, I just looked at one recently and it said folic acid in the form of L-methylfolate. One said folate, and then it had L-methylfolate. And I'm like, well, those are actually two different things. And that's where it's also confusing. Folate usually refers to folic acid, not L-methylfolate. So something that says folate in the form of this, they're not actually the same. So please be careful when you're reading your own labels to make sure that you understand whether your vitamin has both or it only has one and which one does it have. So really, if you have MTHFR, you need L-methylfolate and you need folic acid. If you don't have MTHFR, then you need folic acid. I cannot tell you how much of each. What I will tell you is I do love L-methylfolate, guys. I think L-methylfolate is fantastic. But really, right now, the evidence says you have to have at least folic acid on board. So I hope that answers your question. But it is a very, very complicated scenario right now. So if anybody else has any questions, please feel free to put them into the chat. I know we're republishing one of my older videos tomorrow. I think it's on sickle cell, so you're going to be seeing that. We're going to try to be filming and getting some new videos out. It's been the holidays and you know how that goes, and sickness and family and all that other good stuff. So it hasn't been something we've been able to do, but we have some on the horizon for you. So we're going to try to get that out. And I am going to continue to be here on Mondays at 9 p.m. Eastern Standard Time. Please like and subscribe to the channel. YouTube really wants to see content creators that are growing. That's very important to them. That helps keep me here with you guys. So please, please, please like and subscribe to the channel. I really, really appreciate all of your support. Thank you so much for being here, guys. Thank you so much for supporting me. Remember, go onto the channel, check things out. And I hope you guys have a wonderful evening, and I will see you next week. Bye for now.